So, welcome everybody. Today's topic is PARP inhibitors, recurrence, and what's next with Dr. Sharyn Lewin. So, PARP inhibitors are a type of targeted therapy that's changing the game for people facing gynecologic cancers, especially ovarian cancer. These medications work by blocking cancer cells from repairing themselves, which can slow down or stop tumor growth. And this topic is discussed by Dr. Sharyn Lewin. So Dr. Sharyn Lewin is a fan favorite of Woman to Woman. She is the director of the Division of Gynecologic Oncology at Holy Name. She's recognized both nationally and internationally for performing laparoscopic, robotic, and open surgery to treat complex gynecologic cancers and related malignancies of the upper abdomen, pelvic, colorectal areas. As president and executive director of the nonprofit, the Lewin Fund to Fight Women's Cancers, Dr. Lewin is dedicated to eliminating medical, economic, and psychosocial challenges faced by women with cancer. She serves on the board of the Gynecologic Oncology Group, GOG. Partners investigate counsel, offering key clinical trials to our patients. The Lewin Fund are tremendous supporters of Woman to Woman for our transportation grant, our fertility, our behavioral health program, our reunions. We are incredibly grateful for the support and partnership of the Lewin Fund and to have Dr. Lewin here today. So, Dr. Lewin, thank you so much. And the floor is yours.
Thank you so much for having me. So this is one of my favorite activities to come speak before Woman to Woman because I think this is a model program for all of our gynecologic patients, across the United States. You may know that while I was working at Columbia, we were the first pilot site for Woman to Woman in the country after your model program at Mount Sinai. And then the program really blossomed throughout the country with the support of the OCRF. So it's really just a treat and a pleasure to speak to you today and to continue to follow all the amazing work that is being done with the reunions and all the transportation grants and fertility preservation and everything that's done. It's just a model program for our women. Well, without any further ado, I'm here to talk to you today, though, about PARP inhibitors. I did make some slides, which I'm very happy to share, but also would love this to be very informal because I know questions and answers are very important as well, too. I think I'm going to go ahead and share my screen. So maybe I'll just talk for a few minutes just to kind of educate and give some background, but then I definitely want to leave a lot of time for questions and answers as well. But I wanted to kind of just take a few steps back to talk a little bit about the role of PARP inhibitors in ovarian cancer. The landscape has definitely changed, and certainly to ask and answer any questions that you may have. So, as you all know, ovarian cancer definitely remains a very serious gynecologic malignancy. If it's possible for everyone to mute your line, that would be great. That way there's no background noise until we have questions and answers. That would be awesome. But it's actually interesting because this is the first time in 2025 that uterine or endometrial cancer has actually surpassed ovarian cancer in terms of deaths when we look at gynecologic malignancies. But ovarian cancer still is a very serious cancer. We don't have a good screening mechanism for ovarian cancer. Ovaries, we know, are free floating in the peritoneal cavity. And so by the time we detect these cancers, as you know, they're generally advanced stage 3 or stage 4. We don't have a good screening mechanism, which is why for high-risk families, genetic testing is so important. If we can try to do genetic testing for BRCA and other mutations and identify these women that have high-risk mutations and then remove their tubes and ovaries before these cancers develop, then we've really made a huge impact in the war on ovarian cancer. We also see that the incidence of ovarian cancer has been declining, which is very exciting to see. Part of that is because of what's called opportunistic salpingectomy, where we're removing the fallopian tubes in women who are no longer undergoing interest in fertility. But at any rate, the standard of care now for women with ovarian cancer, hopefully, is to still have surgery up front where all the cancer is removed. That puts women into the best prognostic category. Then to have chemotherapy, and then potentially to have maintenance. And we'll talk about those maintenance options. You know, unfortunately, and what's so tough about this disease is that we do know that despite the best surgery and the best chemotherapy, there's really a high recurrence rate after initial chemotherapy for women with ovarian cancer. And that's really why there has always been such a need for novel, new targeted approaches, and why there's been so much research that's been done to try and prevent recurrences or delay recurrences. And that's really where the backdrop for maintenance therapy and PARP inhibitors came about. It's so interesting, the mechanism of action, you know, for PARP inhibitors. So for those of you that may not know, the PARP inhibitors are oral agents. It's an oral pill that's given. The majority of the work with PARP inhibitors has been done in our BRCA-associated tumors and cancers. So PARP is basically an enzyme that is involved in DNA single-strand break repair. And so if we block this or we inhibit PARP, we have accumulation of a lot of DNA damage. And so it actually helps the cell die, which is what we want to see happen in a situation of cancer. So we know in certain tumors, for example, like BRCA mutated tumors or tumors that have this phenomenon called HRD, which we're going to talk about quite a bit today. HRD is something called homologous recombination deficiency. It's something that's in the tumor itself of ovarian cancer. About half of all women with ovarian cancer, their tumors have this. We test for it with a tumor test. We know that PARP inhibitors work very, very well in women whose tumors have HRD, as well as those women that have BRCA mutations. And so one example, so the HRD pathway is a very important way of repairing double-stranded DNA breaks. One gene that's in that pathway is the BRCA gene. There are many other genes that are in that pathway. But if a tumor has HRD or a woman has a BRCA mutation, for example, there can be a lot of DNA double-stranded break repair that doesn't happen appropriately. And so if you give a PARP inhibitor, which is an enzyme, as I mentioned, PARP is an enzyme involved in single-stranded break repair. If you give an enzyme that blocks PARP, now you have single-stranded break repair that's not happening. And then in a cell, you have double-stranded break repair that's not happening because of the BRCA mutation and the HRD that's happening there in the cell at baseline. It ultimately leads to cell death. And so that's kind of what we want to see happen in a cancer situation. And that's really why we see that the PARP inhibitors work so well in patients that have HRD or BRCA mutations. It's this phenomenon of synthetic lethality is a very big word for that. There are several PARP inhibitors that are FDA approved that are on the market. With ovarian cancer, most commonly, you'll see olaparib, also known as Lynparza. You'll see niraparib, also known as Zejula, rucaparib. And then this fourth one that I mentioned, talazoparib, it's really mostly used in breast cancer. There's some, research that's ongoing in ovarian cancer, but I think by and large, the two most common PARPs that are used in ovarian cancer are Lynparza and Zejula, and probably Lynparza or olaparib really has the market share for our patients with ovarian cancer. Do you want to hear about the data and the trials? Because I have some slides with this. I promise you I will definitely leave enough time for questions. So in the landscape with PARP inhibitors, and feel free to, interrupt me at any point or ask questions. There's been a lot of work looking at PARP inhibitors for newly diagnosed women. That's what frontline maintenance means. We've also looked at PARP inhibitors when women have a recurrence. And we've also looked at it in the treatment setting as well, too, as treatment for women that have ovarian cancer. And we have learned over time that really the best fit for women with PARP inhibitors, by and large now, is for newly diagnosed women. That's really the best setting for women overall. And PARP inhibitors now are best for women if they have a BRCA mutation in their germline, or if they have a BRCA mutation in the tumor itself, that's called a somatic BRCA mutation, or if they have this phenomenon called HRD. So essentially what has happened is that, there was a lot of data that was published, and I'll show you this on the next few slides. And so the FDA approved, PARP inhibitors for a wide range of women with ovarian cancer in various different settings. But as some of this data has matured over time, some of those labels have actually changed for women with advanced ovarian cancer. And so now the window of which we're actually using PARPs for women with ovarian cancer has actually changed. And presently now it's really most exclusively used in women when they're newly diagnosed with ovarian cancer, by and large. That's actually really the best setting to be using PARPs. And it's really kind of based on these main 3 trials. One is called Solo One. This was initially released in 2019, so it shows you how old the study is. But this was a study for women with BRCA mutations in the tumor and the germline. Germline means it was inherited from parents. And this essentially showed a tremendous benefit to the women after, surgery and chemotherapy if they had olaparib or Lynparza for 2 years. And so now it really is the standard of care. If you have a germline BRCA mutation or a somatic BRCA mutation, once you finish surgery and chemotherapy, to be on olaparib as maintenance for 2 years. And that's really in all of our guidelines, NCCN guidelines. And that's why doing the germline testing is so important for women right when they're diagnosed. We see that there's a tremendous what's called PFS benefit, which means keeping these women cancer-free, progression-free survival benefit. And these women are living longer, so much longer once they have olaparib for 2 years. And we're actually curing some of these women who never had a chance at cure before. So that has been a very important advance in the treatment of women with advanced ovarian cancer. And that's for women really with stage 3 and stage 4 disease. PRIMA is a study that enrolled women, all comers, really regardless of their BRCA status. We did see a benefit for all women in that study. The FDA has recently changed the label for niraparib or Zejula, and now it is only FDA approved for women that have HRD in their tumors. So before it was approved for all patients, really regardless of their BRCA or HRD status. But recently this year, the FDA, based on, new data, because as data matures over time, sometimes things change. And now Zejula is only FDA approved for women that have HRD in their tumors. Paula is another wonderful study that looked at the combination of Lynparza or olaparib plus bevacizumab, also known as Avastin, versus Avastin alone. This study also was released in 2019, so it's old enough now the data has matured. And the long and short of it, there was a tremendous benefit for women that have HRD in their tumors to giving them in the maintenance phase, once they're done with surgery and chemotherapy, olaparib for 2 years, followed by Avastin for 15 months. So this is the setting where PARPs are really used the most. This is the best data that we have for PARP inhibitors, is when women are newly diagnosed with ovarian cancer, stage 3 or stage 4, and we really use the decision point to use PARP inhibitors based on their BRCA status and their HRD status. And it's based on really these trials that you see here. The women now who get PARP inhibitors are those that have a BRCA mutation, either in their germline, something inherited from mom and dad, or in the tumor itself, that's called a somatic BRCA mutation, or something called HRD, which is a tumor test. These are the key trials of looking at PARP inhibitors in the recurrent setting when a woman with ovarian cancer has had a recurrence. These were also very important trials. However, we've now learned that essentially we're not giving PARP inhibitors in the recurrent setting. The FDA has changed the label based on how the data has matured over time. And really, the only subset of women who get PARP inhibitors in the recurrent setting are those women who have a BRCA mutation, who didn't get a PARP inhibitor initially when they were first diagnosed, or maybe those women who had a PARP inhibitor when they were first diagnosed and then have had what's called a platinum sensitive recurrence and go on to a platinum-based chemotherapy, then go on to have a PARP inhibitor as well. Some providers will, choose to use a PARP again at this point, or they may use bevacizumab at that point as well too. But we are by and large not using PARPs in the recurrent setting now based on changes to the FDA that the FDA has made with the labels for these drugs, even though we do have data in this setting. It's very important, and we spend a lot of time talking to medical oncologists and patients and providers about the importance of biomarker testing. I think all of you in this group, have heard me say this before and are very attuned to the importance of having genetic testing right when women are diagnosed with ovarian cancer. Unfortunately, despite important guidelines in NCCN, which is our National Comprehensive Cancer Network, that say all women with ovarian cancer should have germline or genetic testing for BRCA and other mutations right when they're diagnosed with ovarian cancer, we see that only about 60% of women are having germline testing. So it's a huge push nationally to be sure that that testing is done universally for all women with ovarian cancer. They also need to have tumor testing done as well. That's what the somatic testing means. And we also need to be doing HRD testing, which is testing the tumor for HRD, these HRD mutations. And really the best test on the market for doing HRD testing is through Myriad's MyChoice. These biomarkers are very important. We're living in an era of personalized medicine. And we know that women with newly diagnosed ovarian cancer, stage 3 and stage 4, these women, if they have a BRCA mutation, either in the germline or the somatic, which means the tumor inherited from the tumor itself, not inherited from the parents, or they have HRD, which, just so you know, about half of all women with ovarian cancer have HRD in their tumors. And about 25% will have a germline or somatic BRCA mutation. So it's a large percentage of women. The standard of care is to give these patients a PARP inhibitor as maintenance once they're done with chemotherapy. So, unfortunately, it's not universally done for all of our women across the United States with ovarian cancer. So it's a big push from an educational standpoint. We're trying to do this for all of our providers across the country. As I mentioned, our current FDA approvals and the current literature that we have really guide us in terms of what we do with PARP inhibitors and how we treat women. So currently, when women are diagnosed with ovarian cancer, as I've mentioned, stage 3 and stage 4, we are using PARP inhibitors in that setting, and that's really the best setting to use PARP inhibitors for women. If a woman has a BRCA mutation, she definitely should go on a PARP inhibitor for 2 years, whether it's olaparib or niraparib. If she has HRD in her tumor, she can also have niraparib by itself for 2 to 3 years, 3 years according to the PRIMA data. Based on the Paula, she can have bevacizumab with chemo, followed by bevacizumab maintenance and olaparib for 2 years. But really the groups of women that do the best with PARP inhibitors are the BRCA mutated patients and those with HRD. It's really not given now for all women anymore. In the recurrent setting, when a woman has recurrent ovarian cancer, we're no longer using PARP inhibitors for every woman with a recurrence of ovarian cancer. And that has definitely changed. The label has changed in that particular situation. If a woman has a platinum sensitive recurrence, which means that the cancer has recurred more than 6 months after her last platinum-based regimen, the data really suggests going back on a platinum doublet. and using something like carboplatin with Doxil and Avastin. The only women that are getting, PARP inhibitors as a maintenance really are those women that have BRCA mutations only. And it's, a little bit controversial among providers what the best maintenance is for the BRCA mutated patients, whether it's to retreat them with a PARP inhibitor or give them Avastin. Certainly, if a woman has a BRCA mutation and never seen a PARP inhibitor, it makes sense to give her a PARP inhibitor after chemotherapy. But the label is no longer just giving it to all women with recurrent ovarian cancer. So that's definitely a difference. And the treatment options for women with ovarian cancer and PARP inhibitors, that label has also been rescinded as well too. So we're no longer using PARP inhibitors as treatment for women with advanced ovarian cancer. These are just some of the common adverse effects with PARP inhibitors. Most commonly, they cause some fatigue, some nausea, some anemia, thrombocytopenia, depending on which one you use. They're actually, I think, quite well tolerated, especially compared to the side effects of chemotherapy. We have it well down in terms of monitoring with blood counts, CBCs, blood pressure checks, checking liver and kidney function. Very, very rare, but serious risk is the risk of what's called MDS or AML. Very low risk, definitely under 2%. That is a risk with the platinums and systemic chemotherapy in general, but something that is noteworthy when we talk about the PARP inhibitors as well and counseling patients. There is, some data that's emerging and some things that are under investigation, just looking at PARPs with immunotherapy. That is something that is of interest. PARPs and ATR inhibitors or other DNA damaging response agents. And there's just a lot of interest in clinical trials looking at different strategies to overcome resistance to PARP inhibitors and to try to figure out why someone might progress on a PARP inhibitor as maintenance therapy. And so it's just an active area of research interest. And I think just some practical considerations to think about is that, again, the importance of testing. We really need to know every woman with ovarian cancer, her BRCA status, her HRD status right when she's diagnosed with ovarian cancer, platinum sensitivity. These are all things that we talk about and think about when we're making treatment decisions. Of course, cost and access issues with PARP inhibitors are important things to think about. The duration of therapy is sort of interesting. Right now, the label says that when women are newly diagnosed and they are treated with olaparib, they're treated for 2 years as maintenance. With niraparib, based on the PRIMA study, those women are treated for 3 years. There is an ongoing study looking at whether or not we can reduce the length of olaparib to 1 year. It's an interesting trial that is enrolling patients to see if we can sort of de-escalate or shorten that time to 1 year rather than 2. And as I mentioned, based on all the clinical trials and all the data, I didn't get into all the data with you in the recurrent setting. I can, but the bottom line is really PARP inhibitors now are best used upfront, which means for newly diagnosed patients. That's really the best spot for women in this disease course, and those that have BRCA mutations, either in the germline or in the tumor itself, or those that have HRD. That's really what the data suggests. We're no longer just giving PARP inhibitors as maintenance to all women with ovarian cancer, and that label has changed this year based on the data that has matured and been presented. So really, in summary, PARP inhibitors have been really transformative in ovarian cancer, very transformative, especially for our women with BRCA mutations, and very transformative for our women that have HRD positive tumors, which is about half of women with ovarian cancer. And there are a lot of ongoing trials to really define optimal sequencing and combinations, and I think where all the research is ongoing now in ovarian cancer are on things called antibody drug conjugates or ADCs. And this is a very exciting area of research. I would be happy to come back and talk about that, Jillian. I don't know if that's of interest to any of the women, but all of the research now in the recurrent setting is really with antibody drug conjugates, ADCs. That's really where all the research is with recurrent ovarian cancer, both platinum sensitive and resistant ovarian cancer, and also in endometrial cancer as well too. So anyway, with that, I think I'll stop and I would be very happy to take any questions. Because this is just a very high level view of PARP inhibitors, but I would really love to see what you all are interested to know about.